like to ask on Dr. Ho to give us an update on intravascular imaging and physiologic investigations in MINOCA, ANOCA, and INOCA. Dr. Prof. Ho, please.
Okay. Dear Chairman, dear panelists, dear audience, thank you for a very kind introduction. My topic today is intravascular imaging and physiologic investigation in the ANOCA and INOCA. And as you know, for a long time, when we mention about coronary artery disease, everyone often think about the atherosclerosis and stenotic coronary artery disease. But as you know, recently we emphasize because of the coronary stenosis, the epicardial coronary artery account for just only 5%. However, and the coronary microcirculation account for a larger proportion, 95%. So recently, all the guidelines consensus focus on the microvascular dysfunction. You see, in the 2024 the ESC guideline for the management of the CCS, they talk about ANOCA and INOCA. And in America, in the AHA scientific statement 2025, we have a four-step of the CAD, which we saw the INOCA along a full the 4 step. And about the distribution of the sex, we saw the sex of the women account for the majority of the case, account for 60 to 80% of the small vessel disease, microcirculation dysfunction. And we talk something about the structure of the coronary microvascular vasculature. We often pay attention to the epicardial artery. It's just for the large epicardial artery from 500 micrometer to the 5 millimeter. But the remaining vessel, we have arterial with the diameter of the artery from 500 micrometer to 100 micrometer, and particularly in arterial and capillary, the diameter less than 100 micrometer. And so the 2024 ESC guideline pay attention very much about INOCA and INOCA. They talk, if we don't see the obstructive coronary artery, we must pay attention. We do not stop. We must pay attention to the remaining. You see, the large proportion underneath of iceberg is the ANOCA and INOCA. So we must not stop. We must continue to do the diagnosis, to do for the management. This is a workflow for ischemic heart disease and the time. We have a occlusive or a stenotic coronary artery. We account for only 20%, and the large proportion, non-obstructive coronary artery, about 40% of the case with the chest band. And about the mechanism, they have a workflow for mechanism in the CCS. They separate two parts clearly, epicardial and microvascular. And epicardial, we have the structural and functional, and the microvascular system is the same. The structural, we have the etiology such as atherosclerosis or intramural hematoma, myocardial bruising, coronary aneurysm, and functional, we have epicardium vasospasm, maybe due to endothelium dysfunction, or maybe a vascular smooth muscle cell or hyperactivity. And in the part of the microvascular, we have the two white SAM, structural and functional. With the structural, we have the invert, the remodeling, capillary rarefaction, intravascular plasmin, and in the functional, it have impaired vasodilation, and we must diagnose by the invasive function testing. And according to the ESC guideline, they recommend we must do predict the likelihood of obstructive coronary artery disease with the first non-invasive and the second invasive. With the non-invasive, we often have the CCTA. And for the functional testing, we have a BED or CMR. And the second step, we have an invasive when we bring the patient to the cath lab. We do the coronary angiogram, and we do the invasive functional testing. And if we have only angiogram in combination with clinical picture, can we get ANOCA in INOCA? And as it was the small study, this the order, the top. A diagnostic test of ANOCA based on only invasive coronary angiogram and clinical data is incorrect. It's with very large, 78% case. So we need the invasive functioning testing. This is the scheme of the ANOCA management of ESC. The first non-invasive evaluation, we have already talked about the last presentation. And the next, we go to the invasive evaluation in the cath lab with some tests, the functional testing with adenosine test or with acetylcholine test. After that, we have the endotype with the epicardial, with the microvascular, with the microcirculation dysfunction. This is a symbol scheme for we use the functional testing, FFR for epicardial, and CFR for the full from epicardial to the micro circulation, and IMR index of microvascular resistance for the distal for the micro circulation. And this is the workflow for review the invasive functional testing with adenosine, with acetylcholine low dose, and acetylcholine for the high dose to evaluate microcirculation, and in combination with the dopamine and adenosine test. This is the scheme of Canadian Cardiology Society in the sham. The first is the adenosine with adenosine. The second, acetylcholine, the low dose and high dose, and then the dopamine. Yeah. And one more, we can do a summary. The invasive coronary assessment for in the INOCA, we have the first, the patient go to the cath lab and to perform a coronary angiogram, and we can consider obstructive or non-obstructive coronary artery disease, myocardial breathing, or flush or ostium branch. And then the next continue, we do a wide-based functional testing guideline with the adenosine test with the value of the normal. We have the FFR greater than 0.8. We have the CFR less than 2.0, and IMR greater than 25. And we perform the test with the acetylcholine. And the last we do interpretation and we give at the end of time, and we diagnose it and give a medicine with the microvascular angina, vasospastic angina, mixed angina, non-cardiac, so on. And the first case demonstration for vasospastic angina, we have a non-obstructive coronary artery disease, and we do the invasive test with the FFR, with the FFR greater than 0.8 normal, CFR greater than 2.5 normal, but the IMR less than 25 is abnormal. And we continue to do acetylcholine coli, and the last we have the result, the vasospastic angina, and we give the treatment, calcium channel blocker, long-acting nitrate, avoid beta blocker, so on. And the second case, microvascular. The same, the first now obstructive coronary artery disease, and we do the invasive functional testing, FFR normal greater than 0.8, or CFR abnormal less than 2.0, and EFR normal greater than 25, and they have the last result, microvascular angina, and give the treatment, the beta blocker, calcium channel, and so on. And in this presentation, this slide, they present the invasive coronary function testing with the endotype, ANOCA and INOCA, endothelium dysfunction, microvascular angina, vasospastic angina, both MVA and VSA, or equivocal response, and impaired vasodilation. And the key message, the patient preference may play an important role in the deciding on the timing of the coronary function testing. Acetylcholine reaching as the diagnostic value by the unmasking coexisting microvascular spasm. This is the remark I done experience. And the continuous thermal dilution allow operator independent assessment, coronary flow and flow preserve. It's the same with my experience, not experience. So, and FFR and IFR and distal pressure drop, focal adhesive, epicardial atherosclerosis, this is the question we must answer. And conclusion. Coronary microvascular dysfunction represent a spectrum of functional and structural abnormality that is still being defined. CMD may be isolated or present in combination with the abnormality in the epicardial vessel and myocardial disorder. Invasive testing can help identify the patient or treat in INOCA. There is still much to learn about the numerous endotypes. Therapy have been very limited in terms of the phenotype-specific improvement and outcome. And the future research in this area will better define pathophysiology more specifically, as well as improve therapy targeted on improved outcome. And myocardial pressure segment are prone to coronary spasm and can present or substrate of angina symptom. Myocardial pressure is best evaluated using the low glutamin stress or unmarked diagnosis perfusion embed a higher heart rate. Atropine as a direct antidote for acetylcholine and inspire and inhibit a muscarinic acetylcholine receptor competitive blocking the effect acetylcholine. I think this conclusion is very important because sometimes we use the acetylcholine test and it have a prolonged constricted. We should remember that atropine is the antidote. And bolus coronary thermal dilution allow a readily available tool to assess the coronary flow of preserve microvascular resistance. In fact, my cat lab have just developed the invasive functional testing, so I don't have much experience about this field. So I like to hear your comment and your evaluation. Thank you so much for your listening.
Thank you very much, Professor Ho. So I think for intravascular imaging and physiologic investigations in this complex area of patients, there's actually a lot more that I think needs to be developed as a community. I mean, with technologies such as coronary sinus reducers coming on board, probably it will make for a big topic in of itself. We are a bit behind time, so maybe we leave all the discussion towards the end. Hopefully we can catch up a little bit.